that, I'm delighted to have the senior Van Sumeren speaking this week. Mark has been presenting some of his COVID-related research to us at CHEPS in various capacities over the past 7 months, and I think this is an ideal time for him to give a good summary of where we stand today. And so I'm going to allow him to give a little bit of his background, and most importantly, I want to make sure we give him as much time as possible, both to review where we've been and where we are and where we might be going, and also have time for questions. So again, thank you so much for joining us, Mark, and welcome, and we'll share your screen.
Okay, bear with me while I get the proper screen up here. Just take me a minute. Okay, that should be visible now to all, I believe.
Yes, we can see it.
Okay, Amy, Renata, thank you very much. It's really my pleasure to join the CHEPS group with this, as Amy said, a very timely topic, and one that I think all of us share a great deal of passion, concern, it's certainly interest in. Certainly speaking to CHEPS is something that's near and dear to my heart. It was really CHEPS' predecessor that launched my healthcare career when I was an undergraduate at Michigan. I won't say how many years or decades ago it was. Rest assured, it was last century though. So it's been some period in time. Just to share a little bit of background, if I can find my slide here to advance the screen. Bear with me, for some reason there we go. I got to get to the beginning of the presentation. All right, I'm not going to read this bio, and Amy thankfully said she wouldn't either. I just wanted to make a few points that I've been blessed with what I think is a very interesting and exciting career, 100% in healthcare since I finished my undergraduate training at Michigan and then my graduate degree there as well. And I've had somewhat of a unique opportunity in that I worked for a provider, what was the Detroit, or is the Detroit Medical Center, when I finished my undergraduate training and while I was in graduate school. I spent 20 years with Ernst & Young. It was Ernst & Winnie at the time, but then Ernst & Young in healthcare consulting. Spent a number of years with a medical supplier where I was responsible for strategy and business intelligence. And since leaving there 6 or 7 years ago, I've been working with a number of device companies, life sciences companies, health systems on various issues. So I've covered really the organizational gamut of the industry, as well as, if you will, the functional gamut. I've been able to do work from operations to finance, mergers and acquisitions, reimbursement, strategy, and supply chain. And now I'm involved in some governance roles. So it's really been a blessing to work with so many great people and great organizations within healthcare. And frankly, there are some people that I continue to work with today that were colleagues and clients 20, 30, 40 years ago. So it's, in many regards, it's a big industry, but it's a small industry. And it's a real pleasure to be able to continue to serve that. So my talk today really could be labeled not how I spent my summer vacation, but how I spent my pandemic. And I'm going to cover a couple different topics. We've all learned a new language over the last 6 or 7 months, things that we really, most of us didn't know of, didn't hear of, are not, test positive rates, herd immunity, long haulers, and the like. But back in March, I don't sit still very well, and being cooped up here in my Ann Arbor home, not being able to travel to clients, not being able to golf, not being able to go watch U of M softball games as I was planning to spend my spring. I was really feeling contained and needing to do something. I was also troubled by the lack of consistent, objective analysis of what was going on with the pandemic at that point in time. And so I started noodling around with the various data sources. And I've reflected some of them here. Johns Hopkins with its Center for System Science and Engineering, CIDRAP, which is an outstanding unit up at the University of Minnesota, which we will no longer talk about this week, given the football game. The Institute for Health Metrics and Evaluation, the Atlantic's COVID tracking project. There's a wealth of information that's out there if you go searching for it. But again, it becomes cumbersome to really get your arms around and get consistent thinking around really what is going on. So I started downloading that information literally on a daily basis, tens of thousands, if not hundreds of thousands of data fields, data elements, and started trying to get my own appreciation and understanding for what was happening, not only in the United States, but in Europe at the time. You recall Italy was on fire, to use Dr. Osterman from CIDRAP's terminology. New York was certainly in a lot of difficulty at that point in time. But so across the country, across the world, and within each state and metro area, I started to try to understand what was going on. And I pulled together my analysis and shared it with about a half a dozen or a dozen friends and colleagues and said, what do you think? Is this meaningful? Does this help you to get your arms around what's going on? And of course, you do that with around a virus and a pandemic, and your information starts to go viral, as you would expect. And what I did at that point in time was open it up for any others that wanted to share in that information. Sorry, went the wrong way. And I started producing this daily report. It's now 6 days a week that I publish this report. And I currently send it out directly myself to just under 1,000 people every day. Now, those 1,000 people routinely turn around and share it within their network. And I find that on an average day, the report is opened somewhere between 2,000 and 3,000 times, individual openings of the information. And in this report, at least the people that are getting it from me, it started out with a group of physicians that I knew and I'd worked with that were working on the front line, clinicians and nurses, health systems executives and managers, medical device and life sciences company managers and leaders. Started sharing it with then some people that I knew in the financial community, investment bankers, private equity folks, at least 3 economists, one of which is on the phone today listening in, and he is not allowed to ask any tough economic questions because he will embarrass my limited knowledge of economics. David, that one's for you. Just all sorts of people on this distribution list. One of the things that I strive to do with this is to keep it objective, analytical, and this is very tough to do in this environment, non-political. Now, my measure of my success in doing this is that I have 2 followers in particular of the report. One is a regular contributor on Fox Business. The other is a regular contributor to CNN and other modes, and a former head of the Center for Medicare and Medicaid Services under Obama. Each of them on a fairly regular basis through their social media platforms share the information that I put out in my report. So I must be keeping somewhat apolitical if both people on both the right and the left are using the information and communicating them within their networks. So I'll take that as a win. So in addition to the several thousand people a day that are using this information for their purposes, there are a few other organizations that I know for a fact are taking it a little bit further. And before I talk about the 2 that I've reflected here, I want to highlight a couple of them, and one of them may be on this call, but one is here in Ann Arbor. You may be familiar with the Ronald McDonald House. Ronald McDonald is charged with the responsibility of providing housing and support to families of children who are very ill and receiving care at Mott Children's Hospital here in Ann Arbor. The leadership team at the Ronald McDonald House, is on my readership and uses the information every day to help them as they plan their activities and their thoughts in terms of how to manage the Ronald McDonald House in the face of this terrible pandemic. And kudos to them for the just tremendous work that they do. The second organization I wanted to point out, and I believe there may be a representative on the call as well, is the state government from Vermont. Now, I'm going to share some information without sharing anything out of confidence here, but the state of Vermont is managing this pandemic better than any other state in the country, hands down, better than anybody else. And they have a whole team that's dedicated to this and doing a tremendous job. I've had the occasion to conference with them to talk about how they're doing it, how they're so successful. And they've shared with me how they use the information that I provide to help focus their attention on looking at how other states are performing. Vermont is a tourist state, summer and winter, and it's very important that they manage the influx of tourists, not to shut it off inappropriately, but also not to allow the infections to spread there. And I'm just proud of the fact that they're able to use some of the information that I've been generating on a daily basis to help them focus their energies on which states should they be paying attention to, which states should they start to think about relaxing some of their restrictions. And you'll see some of the information of just what a tremendous job that they're doing. The other two organizations I want to talk about are highlighted here. And I'm going to start from the center of the screen and work left. One is a medical supplier, just under $1 billion in annual revenue. And the second is a rather interesting one, probably 2 or 3 times the size, and they're involved in dealing with the human genome. They manufacture the instrumentation and the testing equipment used in studying and building out the understanding of the genome. In both cases, these organizations are dealing with not only their own employee base, their own teammates, their operational units, but their customers as well across the country and across the world. And independently, they reached out after having been on the distribution for a while and said, this is great. We really need to drill much closer to understand what's going on in the markets and areas that we're dealing with. So in the case of the medical supplier in the center, they were highly interested in 16 operational sites in the US, Europe, Asia, and Australia, and 208, excuse me, this is the human genome one, I'm sorry, I mixed them up. 208 customer locations across the country and across the world. And I was approached by their risk management team saying, despite having a team working on this, every municipality, every geography, every governmental unit has different rules, different guidelines, different data sources. And in order to keep up with what was going on and to be able to direct their organization of where they could deploy, where they had to scale back, while at the same time providing critical healthcare products and services, they sought out how can we take this information and make it very specific and unique to them. Likewise, the medical supplier was very interested in a number of locations in the US, in Mexico, parts of Europe, and in the Far East. And here I was approached by their chief medical officer and said, we're very interested in following the very strict CDC guidelines, but applying them internationally to decide how do we deploy our resources. So in the one case, we're providing updates twice a week, every Tuesday and every Friday, which they use to help their operational team decide how to plan their operational rollouts. In the case of the Human Genome Organization, we're providing those updates every other week, and it's going directly to their senior executive team, again, making similar types of decisions. Now, just to give you a flavor of some of the things that we are doing here. What we wanted to do, in addition to having very precise and drilling down on the data, it was important to provide it in a visual construct. So they were looking at visualization of what they termed actionable data. Now at the top, I've shown two different visualizations because each organization was unique in terms of what they wanted to measure, what geographies they were interested in, and the specific criteria that they were looking at. They also used different grading scales. The one on the right used a 4-point scale, red for most severe, orange for getting better, yellow for caution, and green for all systems go. The other organization went from red to yellow to green to blue, blue being their designation of ready to go. So in both cases, whether it be twice a week or every other week, we provide this snapshot at a point in time of how each of their geographies are faring against the pandemic using these criteria. We also provide a timeline, which we called a roadmap to recovery, which shows the progression of each of these geographical units over time. Again, the focus and the term came from the chief medical officer of the one organization saying, we need this information to be presented to us visually so that we can react quickly, and it needed to be actionable. Where do we modify our plans based on the way the pandemic is trending? So that's what we have done with those organizations. Now, let's talk about some of the challenges that we have here. If I can learn to advance these slides a little bit better. Let's talk about testing. Now, there are a whole host of metrics that are being used and reported around the pandemic, from testing to cases to hospitalizations to fatality rates, et cetera. Each one of those metrics has its flaws and has some challenges that we need to understand to interpret. Now, the one area, and I was sharing with Amy before we started here, is probably the one metric that we hear the most about is cases. How many cases did we have yesterday or the day before? I'm going to tell you right now that is the least accurate measure that we have at our disposal. And I'll share with you just how inaccurate it is. It's off by a factor of 4 or more. Yet that's the one we concentrate on. But let's walk through each of these. And let's start with testing. So as you probably know, there are different types of tests. Two general classifications are the viral tests, which determine whether or not a person has an active infection or is presumed to do that. And then the antibody test to determine if indeed the person had an infection at some time in the past. Now they have different purposes. And we're going to talk here about the viral tests. And I'm going to distinguish between, for now, the PCR test versus the rapid tests that are being rolled out with Amy's help and others across the University of Michigan. And so looking at the viral tests, there are a whole host of concerns that we need to be aware of as we're looking at them. One, of course, is the availability. Back in March, when New York, New Jersey, Connecticut, Massachusetts, and other parts of the Northeast were having such tremendous challenges, the tests weren't widely available, and you essentially had to be very sick, very significant systems in order to get tested. And so we were finding test positive rates, the percentage of patients that were being tested that were deemed positive, between 25 and sometimes close to 50%, which is very, very high, certainly by the expectations of any type of diagnostic testing, but certainly testing in this case. So availability was a concern, and it has an effect on that detected case measure that I'll get to. Secondly is accuracy. With any of these types of tests, you have the risk of false positives and false negatives. In most cases, we can live with that inaccuracy, but when you're testing, in some days, we will test 1 million people a day. An inaccuracy rate, a false positive rate of 1% or a couple percent or 5% is very significant. A false negative of 5% is extremely challenging. And so accuracy is a concern that we need to be aware of. The third issue is the issue of having an infection versus being infectious. The PCR test, if you follow many of the public health experts talk about the PCR tests, are relatively accurate at measuring the presence of the infection on a person. The issue is that you may be infected, but you may not be infectious at that point in time. The rapid test, which is deemed not as accurate as the PCR test, is actually compares very favorably in terms of its accuracy during the period of time when you're infectious. So Dr. Minna, who's quoted very frequently in the journals and in the social media, would suggest that the rapid test is much more effective, not only because of that, but also the rapid turnaround time in terms of the initial identification of a potential risk to be followed up by a PCR test. Now, just as an aside, I made a trip. Coincidentally, I drove down to Virginia for an annual health physical. And to satisfy my wife, upon my return, I had a PCR test to make sure that I didn't pick up an infection along the way. Part of the reason why was my 92-year-old grandmother was coming, or mother-in-law, sorry, was coming to stay with us, and we didn't want her staying if I had an infection. So I took the test on a Friday and received my result 15 days later. My mother-in-law had already left by that point in time, so it really wasn't effective. The last issue, and one I'll point out here with this graphic, is one of what is being reported on when you report test positivity rates. This graph here shows that statistic for the state of Florida for October 8th. I just picked that date because when I was preparing this, it was the last date for which I had Florida-specific information from the state of Florida. The first graph, the 12.4%, was the data that was reported most commonly by and cited in the literature because it's provided by the Atlantic's COVID Tracking Project. And in the column where they report positive and negative results by state, this is the column that's populated for every state. All well and good. So everybody talks about the test positive rate in Florida versus Michigan versus Vermont and New York. The challenge is for Florida, that represents first-time testees only. So in other words, if you're Nick Saban and you happen to be tested in Florida, your first positive would be counted as a positive and as a test. Your subsequent 3 negatives would not be included in that total. A little bit of a problem. The 8.1%, you can actually calculate that from that same data source, but you have to dig around for it. And that represents viral testing for all persons, first time and repeat. Pretty substantial difference looking at one data point versus the other. The last column, the 4.1%, is what you would find if you went to the state of Florida's COVID tracking, their official health department tracking site. They would say on that day their test positive rate was 4% because they will only report on Florida residents. Okay, so be very cautious. And this is an illustration of people that report, and I think well-intentioned, very publicly about test positive cases and et cetera. You need to be very careful what exactly they're reporting on. And I think many times they're not even sure what they're reporting on. All right, so let's move on. I don't want to diminish the value of testing because there is some value here. And here I've shown, this happens to be a 7-day period through October 11th, contrasting test positive rates by state to the new infection rate. You'll find that there is a fairly strong correlation between test positive rates and the new infection rate. So in spite of all of their problems, test positive rates are still indicative of the infection spread in a state, all other things being held equal. And the lower the test positive rate, the better you are. I'm going to point out 2 states here because they're going to make a difference later. 2 of the outliers that I've highlighted here: Hawaii off to the upper left, South Dakota that's off to the far right. You'll notice that they're starting to deviate from that trend line, and you'll see some implications of that later in just another slide here. Here, I think this is much more valuable. I contrast test positive rates to testing volume. Everyone asks, are we testing enough? And if you were to really answer the question, what's the appropriate level of testing? The answer is it depends. And what this graphic shows, and there neatly fits to a logarithmic line here, that there's a strong correlation of the appropriate level of testing volume to test positive rates. And that if you have low test positive rates, you can get away with, if you will, lower testing volumes. But if you have higher rates, we need higher volumes. Now let's look at those two states that I pointed out. South Dakota is in this, what I call, zone of inadequate testing. They're testing probably 3 times the number of tests per capita than Hawaii, but only slightly lower test positive rates. My conclusion of all of that is that Hawaii's high test positive rate is a derivative of relatively low testing, that if they performed at the level, the testing at the level they should be, they probably have a much lower test positive rate. They were essentially only testing the most visible, the highly symptomatic people, is the conclusion from this. Whereas South Dakota, with very high testing rates, but still a high test positive rate, is probably not even beginning to uncover the degree of infection that was going on in that state at that point in time. That's the correlation between these. Now I want to bring in Vermont. Look at the lower right here. Vermont at this point in time was testing at less than half of where South Dakota was, probably a third of what Montana was testing, but with about a 1 or 2% test positive rate. They were doing more than enough testing, even though it was far lower on a per capita basis than anybody else, because they were doing enough to uncover what limited spread they were experiencing at that point in time. Further testing wouldn't necessarily identify an additional spread. All right, so that's testing. Now let's tear apart detected cases. Now you've probably seen a graphic like this. It gets reported through Johns Hopkins site, the New York Times, a number of other sources, Time Magazine, on a daily basis, shows the graphic and the trend of new infections per million population or 100,000 population in the US. And they will say that the US may be embarking upon our third wave of infections. The first wave back in March, second wave in July and into August, and now the third wave now. There are several issues with this conclusion, which I think in one hand is a little misleading, and in second hand is not really reflective of what may be the underlying circumstance here. So let me tear it apart first. So this is that same graph, but I've now converted it to weekly new detected cases. So essentially I've not divided it per capita. It's just the number of cases on a week by week basis. It follows the same trend. Kind of peaked further to the left side of this graph that I don't show, another peak in July and August, and then picking up another peak today. The challenge with looking at detected cases is it's a function of how much testing we're doing and the test positive rates. Now recall back in March that we were testing probably a couple 100,000 patients a day and getting 25, 40, 50% test positive rates. We're now testing about 1 million people a day and getting about a 6% test positive rate. So you can't argue that the cases we're detecting today are equivalent to what we were detecting later. So how do we solve for that problem? Well, there are at least 2 sources that I've come across. One who I think is absolutely outstanding, Yu-Yang Gu, who's an MIT-trained data scientist who built a model purely based on machine learning to estimate the true infection rate and the implied fatality rate based on the data that was underlying. And then Oliver Wyman also produces some estimates on this basis. I'm very disappointed that Yu-Yang Gu stopped updating his projection model earlier in the month because he was excellent at what he was doing. But let's take this level of detected cases. Now, recall that pattern. That darker blue line at the bottom of this graph is that line. Those are the detected cases per day for that period in time. The taller bars there are Yuyangu's estimates of the actual infections per week that occurred in the United States. Now let that sink in a little bit. Mr. Gu suggests that the actual infections in his estimation are running about 7 times higher than what we are detecting. 7 times higher. Oliver Wyman suggests that it's about 4 times higher currently. That ratio in both of their models varies over time as well, depending on the level of testing, the results that we're seeing in terms of downstream effects, hospitalizations, deaths, and the like, and the test positive rates. And so here's the problem that I had with this obsession with how many cases did we have yesterday versus how many did we have in July, is we're looking at the absolute wrong measure. It has, I don't want to say it's unrelated, it's definitely related, but it masks the true picture of what's going on. And it also doesn't take into consideration the severity of the cases. And so I want to get at that. So when we start to hear about what's happening with cases, my advice to you is let's look beyond that, because there are some severe limitations to case counts. All right, the second piece is that concept that we're in the third wave. So what I've done here on this slide and the next 3 is I'm looking at data state by state, and I'm isolating states that go over 300 daily cases per million population. And so you'll see that if I look at those states that did that back in March and April, it was Louisiana, Rhode Island, Massachusetts, New Jersey, New York, and Connecticut. With one exception, Louisiana, each of those states saw this huge spike and then a tremendous easing that has not reoccurred yet. So there's only really been one wave in those states, not 3. Again, Louisiana being an exception, and I want to come to that in a second. Now let's look at what happened in July. These are the states that saw more than 300 cases per day per million, and it was states across the South and the West, and again, Louisiana. Now, I'll point out Louisiana because the peak that they experienced in April and the peak that they saw in July were completely different parishes. Okay, so even Louisiana, which you might say has experienced 2 waves, really saw one wave in one set of parishes and a second wave in the next set of parishes. And now let's look at this current wave that is hitting us right now in the upper Midwest, in the mountain states, et cetera, and really Wisconsin, North Dakota, and South Dakota. To use, again, Dr. Osterman's phrase, those states are literally on fire, as we see. And they are experiencing infection rates well above anything seen in any other state while we were there. So again, are we experiencing a third wave in the United States, or is it a third set of states, the subsets of the country that are experiencing waves? And what started in the Northeast swung around the South and West and has now dipped through the Midwest in the mountain states to this point. This fall, this winter, as we become shut back in, if you will, we may see a completely different picture. So I reserve that thought process for there. So a little bit on the waves. Now let's talk about which I think is more relevant measures, and that is hospital use and fatality rates. And I will do the best that I can in the time that we have here. You recall in March that we appropriately talked about taking action, shutting down parts of the economy, instituting orders in Michigan as well as other states for the reason of protecting our healthcare resources, our healthcare providers, because there were risks of hospitals and ICUs in New York and New Jersey running out of space. There was a question about the availability of ventilators. Great presentation by some other Van Sumeren last week on his role in solving that. Andy did a great job. The availability of N95 masks, et cetera. So we need to do something very drastic and very appropriate to keep the healthcare system from basically collapsing at that point in time. And that was all well and good and the appropriate thing to do. But what is happening currently? So this is a look at what's happening with inpatient days. These are COVID-19 patients in the United States, tracking by week. The census, if we looked at a same day prior week basis, had fallen some like 58 consecutive days and now has gone up 20 straight days as cases have peaked, particularly, as I said, in the Midwest and elsewhere. There is a tremendous amount of pressure on the healthcare system in Wisconsin in particular. Not in New York. New York's running at about 13% of the peak that they experienced back in March in terms of hospital and ICU use. But it is following somewhat this increased cases. What about ICU beds? Same thing. Was falling dramatically over a period of time, has now picked up throughout the March of October. And even the use of ventilators followed a similar pattern. Okay, so it's a concern and one that I think we need to monitor very closely on a state and a municipality level. But there's another way of also looking at it, and that is among the active cases, what's the likelihood of being in the hospital? As recently as the middle of July, about 300 active COVID patients were in the hospital at any one point in time. As of last week, it's closer to 1 in 100. That rate has fallen significantly. Part of it is that we are identifying more cases, including low symptoms and asymptomatic persons. We're capturing more, detecting more, but the healthcare system has also responded, and we're doing very well, much better in terms of identifying, caring for those patients and not having to be in the hospital as much. Let's take that another step and look at what's happening with the ICU patients. For some reason, this every time I get stuck on this, my slide sticks. There we go. In the case of the percentage of hospitalized patients that are in the hospital or that are in the ICU, back in May, about 1 in every 3 hospitalized COVID patients were in the ICU. Today, it's about 1 in 4. So again, the treatment protocols are improving, requiring less of the more intensive treatment of those patients, which is all good. Now, the real success story and the real learning of what we've done with the healthcare system is back in May, 1 in every 5 hospitalized patients were on a ventilator. Today, it's 1 in 10. We've cut that rate in half. We have found that there are more effective ways of managing these patients than having them on a ventilator, which is all good news. Bad news for Andy's GE company because perhaps we don't need as many ventilators, but good news for all of the rest of us, certainly. And last, if we look at what's happening with visits to the ER and the physician's office, I want to point out, and I apologize for these acronyms, the big red line in the middle, that's COVID-like illnesses. The CDC reports this on a weekly basis, it's usually a week behind. So these data are now a week old. And they look at the percentage of visits that are for COVID-like illnesses. That rate was over 4% in July, and now it's trending just 2.25%, and has been down for the last 6 or 7 days. It's been reporting. So again, fewer visits to the ER and to the physicians for COVID-like illnesses. The other one that we're tracking very closely is the one at the bottom, ILI, influenza-like illnesses, because these also tend to have a significant impact on our healthcare resources. And we are now, I think we are in week 4 of the official flu season. And in a peak flu season like last year, that percentage can go up over 6%. Now, thankfully, for the first couple of weeks that the data are available, those visits are trending lower than each of the last 3 years. hopefully it stays that way. So again, the bottom line of all of this is that while we are seeing an increase in detected cases, the good news is that we're seeing a lessened, a dampened impact on our healthcare resources. So that's all good. What we don't know, and this is a big unknown, is the impact of longer term implications on these patients, what are called long haulers or long COVID. We just don't know how prevalent that is or what that impact is. So a caveat that we need to appreciate as we go forward. All right, so let's deal with really the real bottom line, as Amy and I were talking about, is just how lethal this virus is. And a concern that we have, remember the thought that there were going to be 2 million deaths early on proposed out of this. Fortunately, that's not holding to be true. But let me start with the idea that when it comes to this virus and its fatality rate, age matters. Now, many of you, I suspect, are in that blue band that I have in the middle, the comparison group, the 18 to 29-year-old. I happen to be in one farther toward the right, and that would suggest that my risk of being hospitalized for an infection is 4 times your rate, and my risk of dying from this is 30 times your rate. So that kind of brings pause to me. And if I were my mother-in-law's age, that rate would be 13 times higher for hospitalization. And some, that graph is cut off. I think it's like 600 times greater in terms of death. Now, it's not just because this virus has a bias or an age discrimination factor about it. There's actually an underlying factor, and that is that it discriminates against people that have underlying health conditions. Now, this is again is a CDC report that looked at the presence of a comorbidity in death, whether it be influenza or pneumonia, respiratory failure, cardiac arrest, a whole host of cardiac issues, respiratory issues, diabetes, and obesity that are underlying factors that influence the ultimate outcome here. There was also what's buried underneath there is I think it was something like the average person that succumbed to this disease had 2.5 complicating conditions, not just a single one. So what it really tells us is that this disease is very severe if you had compromised health conditions that disarm you from the ability to manage. Renata, I haven't paused for any questions. You probably have several of them here. And it probably people are chomping to ask some questions. And let me take a break here and a breath and see if you have some.
Yes, we do. We have a lot. So from the beginning, this was like from the very beginning, David is asking, how do you define best, as in Vermont? Is it fewest infections per capita, fewest deaths per capita, smallest rise in unemployment, etc.?
I have a slide that will address that. So great question.
Okay.
Very good question, because it's not one single measure. Yes.
Yes. And this was in reference to the graph that you had that was like a logarithmic graph that you said, is there, and Adam was asking, is there any place on the x-axis where the zone of inadequate testing begins? Even though DC, CT, and New York are doing much more testing, they have quite low positivity rates. Would you still classify them as inadequate?
I would have to look particularly on that chart, and I'm not going to try to work my way all the way back through there. Yes. But again, there's no that line is not precise, and I don't want to suggest that it is, but more indicative that the more you are up and to the right as opposed to down and to the left is an indication that the combination of the testing volume and the test positive rate suggests whether or not you're testing enough. Vermont was a case, they're not testing a lot per capita, but their test positive rate is so low that I think they're more than adequate. Whereas Montana, which again was testing at 3 times the per capita rate, their test positive rate was so high that I suspect they're not identifying nearly the degree of infections that they have in that state. So I think New York's doing a great job with their testing, by the way. Okay.
Yeah.
So.
And then Marissa had a question about, are you seeing inadequate death rates from cases with health issues other than COVID that may have contributed to the deaths? And if so, how are you able to determine those inaccuracies?
Okay, that is the $64,000 question and one of the most controversial issues here because, and it comes down to this. The CDC came out with a report several weeks ago that identified something like, I don't have the exact numbers, between 80 and 90%. I think it's over 90% of people that pass away from or with the virus. And I always use the term with for this reason, is some 90% had complicating conditions. Well, that led to a whole host of individuals in the media, in social media saying, aha, people are misusing this for political purposes because the death rate is only a fraction, less than 10% of what everybody says it is. That is exactly wrong. All they're doing is saying that the person had complicating conditions and it's not that the complicating conditions caused the death. We're also not saying that the virus caused the death, but we're counting it with the COVID deaths. And I shared this in my report, and Amy, I know, liked it. I said, the people that are saying, oh, that means that the real deaths are only 10% of what is being reported. I said, and I apologize, using an unfortunate circumstance like a death. But here's the example. A 72-year-old person with diabetes and a heart condition is a passenger in an automobile driving down the highway. That person is hit by another car and dies from the accident. The person that suggested that these deaths are not due to the virus are saying, because that person had diabetes and a heart condition, they didn't die from the traffic accident, they died from the condition. Mm. That's exactly the wrong interpretation. It's misstating what the CDC said. Now, the flip side of that is, and I think there is some argument to this, logic to this argument, is that if the medical examiner would assign a cause of death, we are, as I've understood anecdotally, and I've had some readers share actual experience with reviewing a death certificate, that we are seeing death certificates that the person had the virus. The primary cause of death was something else, but it's being listed as a COVID death. So we have a little bit of both. I would say the bottom line, though, is if you look at the deaths we've experienced in this country and worldwide compared to what we normally experience in any given year, we are experiencing more deaths. Now, are those deaths caused by the virus? Are they accelerated by the virus? Are they loosely caused? I think there are deaths that we're experiencing because people have shunned going to see the physician, going to the hospital for treatment that they need, and have succumbed as a result of that. Did they die of the virus? No, but they died as a result of this pandemic we're in. And frankly, and this is, to me, the saddest thing, I think we have people that are dying from, frankly, fear, from loneliness, and from other social factors because of being locked in. And I think that's contributing to it. So we can argue all day long, is the death due to the virus or not? Unfortunately, we have more deaths than we typically have, and ascribe whatever reason you want to it. So,
yeah. And we saw that with like in the other talk about like being loneliness and like elderly and things like that. But okay, so Cross has a question about the waves, and he asked, in your opinion, are these waves, were they ended as a result of policy behavior changes on a state level, or just a critical number of people in a given region being infected? Does this explain why the US has not seen similar trajectory, like one major wave as many other developed countries?
That's an outstanding question. There are several different pieces to it. So let me address a couple of parts. One, I think, frankly, what happens when, I do a lot of work with people in New York. One of the roles that I have is on a board of a company a private equity group that's headquartered in New York. I'm very close to a number of the partners there and watched the pain that they were going through as they were in the middle of this. I think that when you're faced with that type of circumstance, people self-regulate, if you will. And I think there's a lot of learned behavior that tends to bring that down. Now, do state or governmental imposed mandates have an impact? I would say yes. I tend to weigh heavily on the behavioral response, which is, and here's my plug, wear your mask. It makes a difference. And I think that people respond to that. And I think people in New York are behaving differently than they did in March and April. They've learned a lot and they don't want to go through that again. All right, so I think that's a significant part of it. The other part, which is kind of what we saw in the Northeast, then going south and west and now in the middle. This virus, it's like water finding its own level. It will find the path of least resistance. And we can forestall it through our behavior, but it looks for weaknesses and it will expand up until we find a vaccine, okay, to be able to cure it. And that's what I think we're starting to see. All right.
And then we do have some more questions, but we only have,
put one
yeah, so if you want to
because
finish,
this
yeah,
answers
if you want to
David's
finish.
question.
Yeah. Okay.
Oh, I wanted to share just a couple of things and then we can get to other questions. Here is what I think is really, really vital to know is if we go back to May, if we look at the weekly deaths per detected case, and I used a 4-week time lag here because the researchers have suggested that there's about a 2 to 6 week lag between infection and death as an outcome. And I selected 4 weeks as not necessarily the midpoint, but there is somewhat of a delay. And then started to look at what's happening with that factor. And the good news over time is that death rate has declined. It's half of what it was back in May. It picked up a little bit in early October. And one of the folks from the state of Vermont, actually, when he saw this, pointed this out to me, said, you know what happened a month before that was Labor Day. And we had a whole bunch of reporting issues around Labor Day that case counts were down dramatically. And so I think that's a derivative of case reporting. So that's one important takeaway. And the last thing I wanted to get before we finish on questions, and again, you'll see there's a lot of material that I didn't get to. This gets to David's question. How do we measure how well a state's doing? And this is a new scorecard that I'm starting to work on now, and it looks at infection rates per capita, week over week increases or changes in new cases, the relationship of tests to new cases. So that ratio really gets at that one exponential graph or logarithmic graph of, are you doing enough tests to detect cases or not? The fourth column there was what percentage, how much are you using your hospital resources for COVID patients versus your peak use of those cases? And then lastly, what is that, going back to that death per 100 case, how are you faring there? Now, I've created this, going from black being most disturbing to blue being very excellent in terms of your performance. Let me point out what Vermont is doing. Blue across the board in every measure relative to each of these other states. They're doing just a fantastic job. Now, if we look, you can look at where Michigan is doing here. Our 7-day new infection rate per capita, here's where I struggled. I'm not quite sure it's green because we've got some growth there. Although you see the growth rate being orange. You see our adequacy of testing being yellow, a little bit of concern. Our use of hospital resources being blue. I sit here as I look out my office, I'm going to share an embarrassing fact that I start downloading this data about 5 o'clock every morning. And during March and April, I used to watch the helicopters on their flight path to U Hospital, which is about a mile away from my house here. And I see the helicopters going almost hourly in March and April. I don't see them anymore as much, which is very comforting. and why we see a little bit of blue here. And then the last one on our death rate, we're performing at a green level here. So David, back to your question. This is the kind of the visualization of how I'm bringing forth now what I think are the 5 most critical measures to take a snapshot of point in time of how any particular state or municipality is doing. I see David staring at the screen there. Does that answer your question? David is an economist. He's one of the leading economists in the country, actually, on real estate issues. You'll see him quoted in the Wall Street Journal and other places. So nice to have David join us here today. A great U of M PhD, Dr. Bierson from U of M, and he's living down in Buckeye territory, down in Columbus. So he's carrying the banner for us down there.
Right. I think we have time. We have 2 minutes, so we have time for maybe like one more question. So this is like a different type of question that I'm not sure if you would have data for this, but I was asking, has aggregate data revealed any significant findings, correlations, and or data gaps relative to COVID-19 and racial health disparities?
Oh, tremendous question. And this really gets at one of the most significant issues that we have. If you look at, and the data are available, and I didn't report them here, there are remarkable differences in infections and death rates based on race and ethnicity, dramatic differences. And again, to use terminology I used before, I don't think this virus discriminates. I think that's reflective of differences in access to public health resources. Secondarily, I think it relates
I agree.
to differences in life circumstances, both home and work. As you'll see, there are reports on this that there are a number of ethnic groups, a number of different parts of our population that live in large family situations where you have a caregiver that goes to a high-risk environment and then comes home to a family, a multi-generational family, and the whole family becomes at risk. Related to that is you have a number of these people who, several of us are very fortunate. We can continue to work remotely. There are a lot of people that don't have that luxury to work remotely. And unfortunately, they work in high risk type environments, and you're seeing a high prevalence of infections among, disproportionately affecting certain ethnic groups, certain minorities. So that is an excellent question. It really gets to the heart of the public health issue that we're going to have to come to grips with respect to this virus and whatever follows it.
Yeah. I think that brings us to 5:30 or 5:31 exactly. So thank you so much. This was very, very interesting. And everyone make sure to check the chat because Amy sent a link so that you can subscribe to get like the daily emails and stuff. And then David also left a really interesting comment. And he said, here's something else to consider. The unemployment rate increased from February to August for Vermont, just 100%. Over the same period of time is 140%. So not only is Vermont doing better by your health measures, it is also doing better by the economic metric. So yeah, thank you so much, Mark. It was a very interesting presentation, and it's really interesting to see data that's non-biased, and it's refreshing, especially in this climate. So thank you so much.
Well, thank you,
Amy,
everyone, for bearing with me. Obviously, I had a great wealth of information that I wanted to share, and I got through probably 90% of it, which was better than I expected. And you were very attentive, and I appreciate the opportunity to share this with you today.
Thanks so much, Mark.
Thank you, Amy.